All right, so here we are at our final presenter of the day, and I will say I think he needs to win the award for the best costume last night at our dinner. He looked fantastic. So please welcome Dr. Michael Mannstadt.
Thank you very much. Thank you for the invitation to speak. And I don't know if the last speaker has a particular task, but I really would like to thank the organizers and everybody who participated here in this just amazing and outstanding meeting. It was simply fantastic. So thank you very much. And of course, last night was a lot of fun, for sure. So I was asked to talk about calcium, albumin, ionized calcium phosphate, and magnesium and potassium. And so I will go through each of them. I would love your participation. And also, I hope to tell you a few little tidbits that might be new to some of you. And I also have several audience questions. All right, so let's start. So calcium, you know the periodic table. This is the atomic weight of 40 and an atomic number of 20, well known to all of us, really essential. And it is essential for muscles and nerves, as we know, and the bones, as we have heard, but also it has a lot of intracellular function within the cell. So some are mentioned here. And we all know how much fun it is to take calcium. So this is first audience question. And this polling is not this high-tech, take out your phones and press something, but it's just the original standard raise your hands. So every day, about 10 grams of calcium pass through our kidneys. Quite a lot. How much of it is taken back up by the kidneys and kept by the body? A, 5 grams, or approximately half, B, 8, or C, 9.8. So who is for A? Normal people or hypoparathyroid? Excellent question, normal people. Normal in the sense of normal parathyroid people. There's no normal people, really. So excellent question. So A, we have one, no, we have none, okay. B, excellent, 1, 2, 3, 4, 5, excellent. C, wow, excellent, very nice. So C is the correct answer for the normal parathyroid people. And so the kidneys do an amazing job in reclaiming lots of things, including calcium. And of the 10 grams, 98% are reabsorbed. And that's the reason why there's roughly 200 milligrams urinary calcium that is normal. And now a word about the intracellular calcium. That's the calcium that is needed for signaling within the cells of the body, that is necessary for enzymes to work and for many, many other things. And guess what? The concentration inside the cell is 10,000-fold lower than in the blood. And there's a lot of fluctuations, because that's how the cell signals, or how calcium signals within the cell. And so there are only a few milligrams if you take all of our cells, what is inside the cell. Yet that's the one that is actually really important for the back and forth. So just as a little biology is full of miracles, and this is one of them, I think. And so now let's talk about the albumin. So we all are familiar with albumin adjustment or correction. And what is albumin? And so it's a protein that is produced by the liver. The liver is our big organ that produces most proteins. It is really in high concentrations in the blood. So about half of all the circulating proteins is albumin. And the concentrations are listed here, and they fluctuate. It has important roles in fluid homeostasis, so to keep the fluids inside the blood vessels and therefore the blood pressure. And it binds calcium, which is then no longer in the pool of available calcium. So we'll talk about this in a second. Now, I am often asked, well, my albumin is not 4.0, it's 4.8. What's wrong with me and my albumin? Or it's 3.4, you know, what am I doing? What is my body doing wrong? And so there's no disease that I know of that is a high or low albumin production, but it changes with a lot of different activities. So someone mentioned here, fluid status. So you drink enough water, then there's a dilution effect, and the albumin might be lower than 4. Or you sit in a conference for hours without drinking, and you might lose some fluids during that time, and so the albumin might go up. So it's not really a question, what is wrong with my albumin, but it's the interpretation of the total calcium that changes with different albumin levels. And so about 40 or 45% of calcium is protein bound, mostly by albumin. About 50% is the ionized one, the free, the active form that the body cares about. And a small percentage is complex with citrate, bicarb, and phosphate. Okay, and so the ionized calcium is really what matters most, but we typically measure total calcium, which can be affected by albumin, and I'll talk more about this. And so audience polling question number 2. Calcium is 8.2, albumin is 4.5. What is the albumin adjusted calcium? A, 8.2. Any takers? Raise your arm, thank you. B, 8.6. Okay, a few. And C, 7.8. Ah, good. So C is correct. And while you might not remember the details of, you know, by how many milligram per deciliter do you correct, to me it's already important to know which direction it goes, right? And so that was correctly answered. And I'll try to, this is working. So I always find it a little hard to explain, but let me try to explain the following. So you have 3 different scenarios. In the middle with what we call normal albumin of 4.0. In the left, a low albumin of 3.0, and here's a high albumin. And here is the total calcium. This is what is being measured as total calcium. So you go to the lab, first person's total calcium is 8, this is 8.8, and this is 9.6. Yet, the ionized calcium is actually the same. And so despite that, the total calcium shows you very different numbers. That is because here, with a total calcium of 8, which sounds low, the albumin is low. And so there's fewer calcium that is bound and inactive. And this relatively large amount of ionized calcium is available, right? And that's why we need to correct. And how do we correct? Well, we use this commonly used formula that was named by the first author of the paper that defined it, Payne. And this is the formula that many of you know. And that's what we just used to get to this result, 7.8. This is for people who use the units millimole per liter. And we all know that this formula is not perfect and has many limitations. One is in the critical ill patient, in the elderly, or very importantly in advanced stages of chronic kidney disease, CKD. Right? And this is well known and people know about this. That's why in ICUs we often actually measure ionized calcium. And so when you adjust this calcium for this relatively low albumin, it actually should be like this, right? 8.8, 8.8, 8.8. So that is kind of the goal for the albumin adjustment, to really judge what the calcium or the ionized calcium actually is, depending on the albumin levels. So far, so good. Any questions so far? All right. But now comes the little surprise, and I'm sorry that this is the last talk of the meeting that you hear. And that is the question, how well actually does albumin adjustment reflect ionized calcium? And so this is polling question number 3. How well does albumin adjustment calcium do compared to just using the total calcium without albumin in most clinical settings? A, it's actually worse than the total calcium in more than 10%. B, it's better than the total calcium in about 30%. And C, it's better than total calcium in about 80% of cases. So who says A? No one. B. Wow. C. Wait a minute. Nobody. What is D? Say, what is it? No one knows. No. What is it? Brain fog. Brain fog is setting in. All right. And does anybody have an opinion? Which one is the C? So C would mean that it is better to use the adjustment in the majority of cases, but there are some, like 20%, that is not fine, right? Yeah, so that's an answer that I would have given some time ago, but the reality looks a little different. And so first of all, this is, you don't need to remember any of these, but this is just a historic note on how this formula actually came to life. So this was a study that was published in 1973. So what is it, like 50 years ago? And what they did is a little funny these days, because the rigor of investigation has really improved over the years and decades. And that's not a critique on the authors, it's what was done at that time. And so they took 200 patients, and I cite from the paper, who are likely to have a low prevalence of disorders of calcium homeostasis. Without measuring it, it's just assumed. And they developed this formula to adjust for calcium. And they took a lot of patients, all of these patients actually had liver enzymes tested. And at the same time, they tested the the total calcium at that time, and they assumed, well, they have liver disease, they don't have anything wrong with their calcium. So the critiques are, there's no validation. They don't compare it to a gold standard, the gold standard being the ionized calcium. They didn't measure the ionized calcium. They just said, well, these people come for liver diseases, their calcium should be fine. 20% turned out actually to have high protein levels because of multiple myeloma, a semi-malignant disorder that can lead to high protein levels and really changes calcium. The methods that they use for the calcium and albumin measurement is no longer in use. And the formula they designed was only for patients with low albumin, not for high albumin. And the statistical methods that they use would no longer be sufficient actually for publication, right? So the birth of this formula was kind of not what rigorous science would assume nowadays. So there were many or several subsequent studies that tried to investigate the question, well, how good is it actually, this formula, when you compare to ionized calcium? And so one was a large nationwide study in Norway, and this slide is full of data, and that is okay, I'll just walk you through it. So they took a lot of patients, right? More than 6,000 patients, in and out patients, where they had in a single blood draw measured what we are really interested in. And they used all kinds of different formulas. One is the pain formula, compared to no formula, meaning just taking the total calcium. And then they used several other formulas, and they developed one they were very proud of, actually, because it was locally for Norway developed. And then they give you results left for people with normal kidney function, which means an estimated glomerular filtration rate of more than 60, and on the right side, people who had diminished renal function. And the number that is shown here, the higher the better, meaning the higher the number, if it's close to 1, then it will be exactly what the ionized calcium actually shows us. And if the number is lower, like 0, then it has no association with the ionized calcium. And so I don't know if you can see it from afar, but the number here for no adjustment is 0.749 or 0.801 for people with low kidney function. And then when you look here, almost all of the formulas are worse than the non-adjusted one. This is for people with normal renal function, and this is also true for people with a diminished renal function. So meaning it not only doesn't improve our prediction of ionized calcium, it's worse than not using albumin, which I don't know how you feel. I feel it like a shock. Let's see, there was one, this one, for instance, is slightly better, but overall, you see the picture, right? Okay. Now, these are details for that, and again, I don't want you to see every little thing, but on the left side, these two graphs are for people with normal renal function, and these are below normal renal function. And these are different calcium values here. This is for low calcium, and this is for high calcium. And the black curve, which you see here, for instance, is the unadjusted, and all the others are different adjustments. And the higher the curve is, the better it does, meaning the higher the curve is, the better it reflects what ionized calcium shows you. And you see here, black is the unadjusted. This is in this bar. Black here is actually one of the highest ones, meaning the best ones. Here it's actually, other curves are better, and this is for hypercalcemia, where the adjustment actually seems to be a little better. And here's the black curve is somewhere here. So the same thing that I just showed you in the table, just as a different graph. All right, now what about another study? So this is a very recently published study from Alberta in Canada. It's a population-based cross-sectional study where they took patients who had a simultaneous determination of total and ionized calcium. And the goal was to see how does the unadjusted versus adjusted total calcium actually fare compared to the gold standard of ionized calcium. And now what this study sets apart to many other studies is the pure size. 22,000 patients they started with. Approximately half were females and the other half males. And these studies are long and there's lots of data, right? And so I'll just show you the results. And that is, again, this number, the R square, the higher the better it correlates to ionized calcium. Total calcium, 0.72, pain formula that we use, 0.6, and a simplified pain formula, 0.69. Again, remember the higher the number, the better, right? So, and the authors say, in this cross-sectional study of 22,000 patients, adjusted calcium levels were mostly correlated with ionized calcium. These generally fared no better than unadjusted total calcium alone and had the tendency to systematically underestimate true hypocalcemia and overestimate true hypercalcemia. Pretty sobering, right? We are not talking about black and white, right? It's not like totally wrong. We are talking about how much better do we do with the adjustment, and I couldn't find lots of data that show we are doing a good job with the current adjustment. And actually, there's a question that always comes up is, well, my calcium doesn't always, and people usually say my adjusted calcium doesn't reflect how I feel, right? And I sometimes wonder, does this have something to do with our adjustment? So there are many challenges. One big challenge is, well, this was compared to the gold standard ionized calcium, right? But this gold standard has its own difficulties. And that is, it can be unreliable if the blood sample isn't handled just right. What this means is, It needs to be collected in a certain way. It needs to be handled fast. Our hospital is put on ice. There's no oxygen has to come in because that can change the pH. And when the pH changes, the ionized calcium changes and has to be rapidly actually measured. And it cannot be sitting around like other tubes when you see, okay, they're sitting and you're leaving, this is not possible for a good ionized calcium measurement. So that is one of the biggest challenges. And by the way, that is also the only reason really why we don't routinely measure ionized calcium, because it's so complicated and fraught with mistaking numbers because of the handling that cannot be always guaranteed. What I didn't know is albumin. I always thought this is kind of easy peasy to measure, but it's not. When you talk to laboratory people, they will tell you how difficult actually it is to nail it to the correct number. Different laboratories use different methods. And I don't want you to leave with thinking, oh my God, the whole calcium measurement is, the basis of our being is now not clear. I would say that both the total calcium and the albumin-adjusted calcium, they do get it right in most instances, right? But the value of the albumin adjustment is just not clear. So one question is, what should we do? In theory, it makes sense, but practically the data is lacking that it's actually superior. And so there are these options. The nuclear option is one, abundant albumin adjustment. Measure ionized calcium or rely on total calcium. The second option is to continue, and the third one is to lobby for the development and validation of a new formula or approach to this problem. And as always, as you know with research, it costs time and money and a lot of will to do this, right? Some of these publications actually try to get to that question, and I hope we'll get some more insights in the future. And as I said, the calcium measurements generally are quite reliable, but there is a little bit of doubt in my view now on the value of the albumin adjustment. And by the way, there are many clinical trials obviously going on. It would be nice if the budget allows to actually measure ionized calcium too, and to then compare, how does it fare versus the total or albumin adjusted calcium. All right, I think that is all for the calcium. Let's see if I can go back. Yes. Any questions?
Okay, I just have a quick question, and it's in regard to like regular labs like Quest or LabCorp, outside of a hospital setting. Are they collecting ionized calcium, or is that a special request?
Do they measure ionized calcium is the question? I don't know. I think the bigger the lab, the more likely that they measure ionized calcium.
So my lab claims to do ionized calcium, but they also claim that they have a, quote, stabilization protocol that allows them to hold it until they run their twice daily lab samples out to like another lab 3 hours away. Is that real?
This other lab 3 hours away that is measuring ionized calcium?
Yeah, they're measuring the ionized calcium.
Yeah.
So it's sitting for like 5 hours.
Right. Now, I'm not a laboratory clinician. They will be best to answer that. The methods that our hospital uses, you cannot have it sit for 3 hours or 5 hours. It would likely deviate from the real level.
Yeah, that's my feeling, but I was just like, I've never heard of a stabilization process that would allow you to hold it, so
right.
I think it's garbage, but I just wanted to check and see if you knew of one that existed.
I would be careful, actually, because there might be a method that somebody developed that allows for exactly what you're saying, right? Now, the question is, how good is it? How was it validated, right? Because I've heard about this before from a reliable center that they kind of leave it and do the stabilization, right? I don't know. I don't know if anybody else has more experience with this stabilization method. No. Okay.
I don't have experience with the stabilization method, but what I will promise this community is, so I used to work in a hospital laboratory, I will reach out to my hospital laboratory friends that I still have and ask them if they have heard of such a thing, and then report it out on our website.
Great. And we have time at the end, hopefully, for also other questions. So next is about phosphorus. And this has a very fascinating history. So it comes from the Greek phos, light, and phoros, bringing, so the bearer of light. And you might have seen this depiction of how phosphorus was detected. It was discovered by Hennig Brand, who was looking for gold, as most alchemists at that time did. And what he was using, and now this will get your attention, 60 buckets of urine, because he thought he can do something to that to make gold out of it. And so he got rid of most fluid, and then at the end, actually, it caught fire, because phosphorus, which is in the urine actually a lot, burns with a white flame. So he almost discovered gold. He discovered phosphorus. And so, by the way, phosphorus was used actually also in matches, right? Because of its burning capacities. So polling question number 4. Higher serum phosphate levels are associated with A, higher muscle mass, B, mortality, or C, meat eaters. So A, who's for A? Brain fork or no one? Okay. B, mortality. 1, 2, 3. C, meat eaters. Most of them, ha! Most of you were wrong. It is actually associated with mortality in the population.
Really?
Yes, really. In the population, which means normal and abnormal people altogether. So this is another very interesting element that is essential for many important functions. Skeletal health, we know, it is in hydroxyapatite. Energy metabolism, the P of the ATP. DNA and RNA contains phosphate. For cell signaling, so that nature discovered that if you put a phosphate on an enzyme or take it off, it changes the activity of the enzyme. And glycogen and glucose metabolism. High serum phosphate is what is typical for untreated hypoparathyroidism, as we know, too much phosphorus in the blood. PTH is very effective in getting rid of phosphate through the urine. It tells the kidney to discard the urine. And if you don't have PTH around, then there's high serum phosphate, which is claimed to drive vascular and soft tissue calcifications. And as we just said, on a population level, the higher the phosphate, the higher the mortality, right? So it's something to be serious about it, although this is asymptomatic. Whether your phosphate level is 4.5, 5.5, or 6, you might not actually feel any difference. And so I separate the treatment of hypoparathyroidism on conventional therapy to PTH. The results are very different with regards to phosphate. So as you know, phosphate is often high or high normal. It actually often, quote unquote, normalizes or gets lower when the calcium goes up. So you have somebody who's not on calcium calcitriol, calcium is very low, phosphate high, you start treating with calcium calcitriol, typically calcium goes up and phosphate goes down on its own, probably because of another hormone called FGF23 that leads to the excretion of phosphate. I personally check it from time to time to ensure that it's not frankly high. I don't check it like every time I check a calcium. That's how I do it. And it's difficult to not have phosphate because it's in most food items. Some of them are rich in phosphate, and there if your phosphate is consistently high, you want to consider a nutritional consult. They're very good in knowing about phosphate because of chronic kidney disease. People have high phosphate, and they have very good knowledge about what food to modify or restrict. And soft drinks and colas have a lot. processed food and meat has a lot, and fast food. So these are kind of the low-hanging fruits, if your phosphate is high, to reduce the intake of those. And then many of you might know that calcium can bind phosphate in the food. So if you, that is one of the reasons why we typically recommend taking calcium supplements with food or right after a meal, right? Because it can bind the phosphate, and then the phosphate doesn't even enter the bloodstream, and not leading, hopefully, to elevated phosphate. All right, and so this picture totally changes when you are on PTH or PTH analog, because they are very effective in telling the kidneys to get rid of the phosphate. And so it's no longer really a problem in most patients, although we have at one point during the meeting somebody said actually despite PTH treatment the phosphate is high. That's unusual. And actually on the contrary, I have many patients whose phosphate now is a little on the lowish side. Typically doesn't cause any symptoms, but to me it might be a sign maybe there's a little too much PTH that's given, right? And so I then, if it continues, I ask, well, is the calcium maybe a little higher than we need, and can we actually reduce the PTH? So this is what I had about phosphorus, and maybe if you keep your questions, if there are any, and we can do them at the end, might be easier. Magnesium, very interesting metal. It burns brightly with spectacular white flame, and I don't know how many of you, as a kid, have actually burned magnesium in the basement. It was spectacular, as was the reaction of my parents. It is the lightest engineering metal and a fairly tough metal, and so it's being used in race cars and others. And also in aeronautics, it is used either pure or in alloys with aluminum. It's used in fertilizers, glue, cement, batteries, etc. And so the audience question number 5 is, what magnesium abnormalities in the blood can lead to hypocalcemia? A, only low magnesium, B, only high magnesium, or C, low and high magnesium? So who's thinking about A, low magnesium? Excellent. B, all right. C, okay, and the majority is correct. It is, interesting enough, both very low and very high magnesium levels, which is always an astonishing fact, I find. So the name for this actually comes from a town in Greece called Magnesia. It's very abundant in nature and abundant in food, especially green vegetables. Again, very important for many functions, including ATP, enzyme reactions, etc. And the kidneys are the primary regulators of magnesium concentrations. And so there is actually a very complex relationship between PTH and magnesium. And it's not as easy as like calcium. PTH increases calcium, that's it, or phosphate, it decreases. Here it's a little more nuanced. So PTH can increase the reabsorption, meaning the reclaiming of magnesium in the kidneys, increasing magnesium. And during the meeting, this was shown in at least one graph that magnesium levels actually can go up on PTH treatment. Magnesium also binds and activates the calcium sensing receptor. So similar to calcium, if there is a slightly low magnesium level, it can stimulate PTH in people who have parathyroid glands. And then comes severe and prolonged hypocalcemia. So that blocks the secretion of PTH in people with parathyroid glands, and also can lead to a target organ resistance to PTH, probably both to endogenous PTH and PTH that's given. And therefore, it leads to hypocalcemia and PTH not longer working. And severe and prolonged hypomagnesemia should really be avoided, also in hypopara patients, especially when you're on PTH. The contrary, the high magnesium level is something very rare, and there are examples of eclampsia during pregnancy that is treated with very high doses of IV magnesium that can actually lead to high magnesium levels and then subsequently hypocalcemia. Now, mildly low magnesium levels are or low magnesium levels might give non-specific symptoms like lethargy, muscle cramps, and muscle weakness, and can easily imitate hypocalcemia. Why do people have low magnesium levels? Well, diuretics are often the cause. They can lead to higher magnesium losses in the kidneys. Some malabsorption, GI, gastrointestinal issues like chronic diarrhea. And also, some studies claim that proton pump inhibitors for acid reflux can lower magnesium. I have one patient who actually has low calcium simply from PPI use and low magnesium levels. Then there's also a problem with what does the measurement of magnesium really mean, and because very little of the total magnesium stores are actually in the blood, and so the blood levels might not always correlate what is in the tissue, making the whole magnesium field a little difficult. All right. Potassium. So I was asked to talk about potassium, and the organizers asked me in my talk if I can add a little bit of politics. So I thought this is a great example of doing that. And so the unofficial audience polling here is, what is common between politics and potassium? Okay, well, that's a nice little thought. It is both can cause problems when the levels get too high. Okay, so now the real question is, what contains the highest amount of potassium? 1 medium avocado, 1 cup of cooked spinach, or 1 medium banana? So who's A? No one? 1, 2, excellent. B? 1, 2, 3, 4, excellent, 5. C, ha. All right, so C is not correct. And some knew that. It's this old saying of bananas, right? They have a lot of potassium. Well, they have potassium, but the numbers are here on the right side. So a medium banana has 420 milligrams, so it's not nothing. Medium avocado, more, and a cup of cooked spinach, almost double from a banana, okay? So typically, actually, I should first say this is also important for all kinds of functions. But potassium problems per se in somebody who has normal kidneys and eats, like a Western diet, typically there's no potassium problem because this is handled very efficiently by the kidneys. And low potassium typically is caused by diuretic use again. Vomiting, diarrhea, and insulin use. So diabetics know that the potassium can go down when insulin is given and can lead to all kinds of symptoms. High potassium is typically seen in advanced renal failure or with certain drugs. And that's actually really dangerous and can be life-threatening if it's high and needs to be treated in the emergency room. But there's a high level of potassium in red blood cells. And so if blood is drawn and during the drawing or the handling, the red blood cells are destroyed, then this can lead to artificially high potassium levels and a lot of excitement, but it's just hemolysis of the blood draw, not really what is circulating in the blood, right? So that is a well-known fact and good for you to know. That this can be just a false reading, especially if somebody who has no reason and had normal kidney functions. But in hypoparathyroidism, really there is no direct relationship between potassium and the hypoparathyroidism that I know of, but of course indirectly, like thiazides that are being used to reduce urinary calcium can reduce potassium, which is well known. That's why after somebody starts hydrochlorothiazide for the first time, we do measure potassium after a few days because it can be so low that you do require potassium repletion. And of course, kidney function, I told you about, that can increase the potassium levels, and arrhythmias low calcium levels can be associated with arrhythmias, and so if there's then also a high potassium level for whatever reason, can be the intersection. All right. So that is what I wanted to tell you, and I hope we still have a few minutes for questions if there are any. Thank you very much.
All right, who has questions in the room? Michelle, do you have any online?
One of them online is, I have a child with genetic hypopara. They're a teenager, and their phosphorus level has always been high, but their endocrinologist says that it doesn't need to be taken into account. And you mentioned a high mortality rate. Can you please give more details, and if we should push for changing something in their treatment based on high phosphorus?
Yes, no, thank you for the question. So let me tell you a few things. One is the normal phosphorus levels, the normal range changes with age. So in childhood, the normal phosphorus level is higher than in adults. So if a baby has a high phosphorus level, the first question, well, is it within normal range of the age? And if it is, then nothing needs to be done, okay? So there is an age-related normal phosphorus level that I'm not a pediatric endocrinologist, but pediatric endocrinologists are very well aware of it, and not everybody else might be. The second thing is, I'm glad you asked about the mortality, and I didn't want to scare people. This is, in the general population, has probably something to do with kidney failure, and just tells us we should not take it too lightly, the phosphorus, right? Because there's no symptoms and we cannot do much about it, etc. It doesn't mean for the individual person, when the phosphorus level is 5.5, you will die or something. That does not mean it. But if it is higher than the normal range continuously and not just once or twice, then it would be good, in my view, to try to address that. And it might be more difficult in children because it might be difficult to influence what they eat. But food is one potentially easy way to lower the phosphate, as I've said. And then Dr. Schobeck had mentioned that in some people, phosphate binders might be necessary in addition to just taking the calcium with meals. And phosphate binders are medications that are made for people with high phosphorus, especially chronic kidney disease. They can be expensive. It's a nuisance to take more medications, so that needs to be evaluated by the physician.
Okay. And I have one that is asking about, you talk about the unreliability of getting accurate calcium levels. What does this mean in terms of developing the calcium monitors for home? Do we think those will be even less accurate because calcium is so hard to find a stable method?
Yes. So what I wanted to say is that this albumin adjustment needs to be questioned a little bit, okay? And it might be good for people with high calcium levels. For low calcium levels, there is very little data that shows us that it's actually beneficial as opposed to total calcium. With respect to home measurements, it would be fantastic to have them. In my view, one of the advantages would be you wake up in the morning and you feel lousy and you don't know, is it you didn't sleep well or is it the calcium? And so maybe it's the calcium. You have a little bit of tingling, so maybe it's low, but you remember once you had high calcium, you also had tingling, so is it now high or low calcium? Should take more calcium or actually less? And how will you ever know? Going to the lab takes time, etc. Having a home measurement would be ideal. Even if it's not perfect and not absolutely accurate, it could tell you, is it 7 or is it 10? Right? And so that to me would be a really nice addition to the self-management of the disease.
This one is asking, are there things that we should be aware of that affect our ionized calcium, such as hyperventilating, or if you've walked a lot right before you go get tested, do things like that affect our calcium and how they correlate?
Yep, that's a good question. Hyperventilation can change the pH, and when the pH changes, then the ionized or the calcium and ionized calcium change. Yes, but typically, once you reach the lab and you sit there for an hour, the hyperventilation has gone down, I hope.
Your blood pressure went up, but
Yes, that's right. That's correct.
do we have some in the room, or I have more, but.
Okay. Any other questions in the room?
To get what checked? Sorry, is it expensive to get what checked? Well, I mean, all labs cost money. There are some that are very expensive, like bone turnover markers, and others that are not, like albumin. Ionized calcium should also not be that expensive, as far as I know.
Okay, Michelle?
This one is asking if albumin was high before starting PTH, but now it is low after starting PTH. Is this what causes blood pressure changes? Because you talked about the albumin can affect blood pressure.
No, it has nothing to do with that. The albumin changes in our normal range have no impact on the blood pressure.
Okay. Any more?
I don't have any more questions at the moment, but I do have a comment. I texted one of my lab friends about the ionized calcium stabilization, and I have a response immediately for us. There is a way of stabilization that is acceptable in a hospital laboratory that they will accept from an outside laboratory, but it's complicated and it requires sealing and chilling this specimen within minutes to 4 degrees Celsius.
Wow.
If it is not done within minutes, it is not stable beyond an hour.
Wow. Well, thank you very much. That's fantastic. Great.
So
Good.
unless your lab is chilling it before they exit the room with you, not acceptable.
All right.
And the,
That was the response I got.
and the difference between the online audience with the questions and our audience here is that they don't need to go home. We want to go home. So the tourniquet, yeah, this is, there are books written about this, right? So the tourniquet, or also standing up, can change the concentration. So for instance, when you stand up, the vessels, there's more pressure in the vessels to actually put fluid out in the interstitium and leaving more concentrated stuff behind. And this has been well established in hematocrit. Hematocrit changes when we lie flat versus we stand up, the measurements, right, by 10% or something. And very similar, actually, the calcium. The tourniquet has the additional effect of maybe causing, if it's too long on it, a lower pH. And with pH, the ionized calcium changes.
So when we get our blood draw, is it a good or a bad thing?
There's in life you have to have a balance between what is perfect and what is doable. And so, unless you have difficult veins and the tourniquet is on forever, it might actually change results. Otherwise, I would be too concerned about this.
Good practice for drawing blood is that you use the tourniquet to find the vein and then release it as soon as you've entered, and that alleviates some of that.
All right. Thank you, Dr.
Thank you.
Mannstadt. All righty. So here we are. We are at the end of this conference. I really wanted to, again, thank our AV team. You guys are just exceptional. I mean, fantastic. All of our sponsors, our medical team, Bob, Katie, and particularly I need to thank Michelle for all the work that she put into all the details of what it's like to be in Texas. So thank you so much for all of that. So really, as we reflect on our time, we've shared knowledge, we've built connections, we've strengthened our voice. I really do believe we have strengthened our voice in here. We have promising science that's moving us forward with new treatments that's going to help us celebrate choices in the future. We welcome new patients and physicians to our team. And all of this reminds us that we do not walk this alone. It takes all of us. This weekend was a spark, and a spark that we want you to take back to your families, for our medical advisors, take it back to your clinics. There's a lot of courage, a lot of hope that's happening. So carry this spark with you, and thank you for coming, and we hope to see you next year. Safe travels.